Oh, welcome everybody to this evening's lecture. Vet Education is proud to present a free webinar on the acute abdomen in the cat. This lecture has been brought to you by the upcoming Vet Education online course. It's called Feline Emergencies. It's a 4-week online course, starts November 15th, so in about 12 days time or thereabouts. So thank you so much for coming along. We love doing these free webinars. They're usually a great opportunity for us all to have a bit of a chat about things. And tonight we're actually talking about something incredibly interesting. We always talk about interesting things, but this is particularly interesting because it's about cats and their secretive ways in their abdomen. The plan tonight is just to talk about how we approach acute abdominal disease in the cat, and then what we're going to do, because cats are unique and they don't always tell us what's going on in their abdomen, we're going to have a trawl through the literature over the past 10 or 20 years or so, just to have a look at what the literature tells us that cats tell us about what goes on in their abdomen. So let's get underway. Let's start off with the definition. What is an acute abdomen? Well, an acute abdomen is really a term that's used to describe an acute or sudden onset of abdominal pain. And it's frequently a sign of quite significant and potentially life-threatening abdominal disease. Most of us, when we think about acute abdominal pain, particularly when it comes to the dog, we think of things like gastric dilatation, vulvular syndrome, or intestinal perforation, acute abdominal hernias, for example, from bite wounds or other sorts of trauma. So usually there's something pretty significant going on in the abdomen. We might have rupture of the intestines, we might have rupture of the urinary tract, we may have penetration of the abdominal cavity, all of those things that we've just mentioned. It's interesting, and the reason why we've titled this talk, The Acute Abdomen in the Cat, is that cats are a lot more secretive about significant, potentially life-threatening abdominal disease. And so the actual term acute abdomen in the cat, while it refers to acute abdominal pain in the dog and indeed the person and in people, in cats we really want to think about the acute abdomen as an acute onset of significant, potentially life-threatening abdominal disease that may or may not give rise to the presence of abdominal pain. And we're going to talk about that in a lot more detail as we progress through the session tonight. So what are the causes of acute abdominal disease in the cat? Well, there's similar things to what we expect to see in dogs as well. Cats will occasionally ingest foreign bodies, albeit not quite with the same frequency as dogs do, but they can ingest things like string foreign bodies, for example. When they're playing, they can ingest small fluffy objects and those sorts of things that can get stuck in their intestines. Intestinal obstruction can occur not only due to foreign bodies, but certainly through neoplastic lesions, for example, intussusceptions, those kinds of things. Cats can suffer from intestinal perforation, be that from a luminal foreign object that erodes through or leads to pressure necrosis through the intestinal wall, or they can also have intestinal perforation through penetration of external objects, things like slugs, for example, from slug gun pellets that can penetrate the abdominal wall and in fact perforate the intestine as they travel through the cat. Intestinal ischemia is a really interesting one. We typically associate intestinal ischemia with maybe things like severe shock, for example, but intestinal ischemia can also occur due to the presence of foreign bodies putting pressure on the intestinal wall. But one of the most common causes of intestinal ischemia in cats is actually blunt force trauma. So if a cat suffers a dog attack, a crushing sort of injury from dog jaws being wrapped around the abdomen, or perhaps a cat gets hit by a car, for example, and they suffer some impact from that initial trauma or impact when they land on the ground afterwards, that bruising to abdominal organs can result in intestinal ischemia and potentially not only just damage the blood vessels, but eventually perforation as well. Intestinal neoplasia in cats can be quite aggressive and can certainly cause significant gastrointestinal disease, vomiting, diarrhea, maybe even perforation or even obstruction of the intestine. Colitis, disease like intussusception, which we'll talk about in a little bit, and also just functional or structural ileus. So we can have physiological ileus where we get paralysis of the intestines due to a decrease in parasympathetic nerve supply to the intestines, or we can get a structural ileus due to the presence of a foreign body or a neoplastic lesion and so on. Urinary tract disease can also cause serious abdominal disease in the cat and occasionally acute abdominal pain, and urinary tract obstruction where we get urethral obstruction due to the presence of urolithiasis, for example, or mucus plugs can cause quite significant bladder distension, and certainly in my experience that's probably the most common cause of acute abdominal discomfort to do with the urinary tract that we see. But sometimes animals can suffer from urinary tract rupture, either as a sequela or a sequence to urinary tract obstruction, or potentially as a sequela to blunt or sharp abdominal trauma. So again, road traffic trauma, dog attacks, and those sorts of things. Cats can suffer from urinary tract infections when the kidney is involved and the renal pelvis is involved in those infections. We can get pyelonephritis, and that can cause significant swelling to the kidneys and stretching of the renal capsule, which can be quite painful in animals. Urolithiasis, we've already mentioned, be they causing obstruction or even just scratching or irritation to the urinary tract. Acute kidney injury is another potential cause of acute abdominal pain in the cat. Any time when you get acute kidney injury or acute kidney failure, you can get quite significant swelling of the renal parenchyma and again stretching of the renal capsule causing quite significant kidney pain. One of the cases which I see cause pain, the most significant pain with regards to acute kidney injury, is in cats that develop acute kidney injury secondary to ingestion of ethylene glycol, so antifreeze, because that particular toxin leads to the deposition of calcium oxalate crystals right throughout the renal parenchyma and the renal tubules and causes significant obstruction to the urine flow through the kidneys, and subsequently we get a big swollen inflamed kidney that causes quite significant pain. And neoplasia is another potential cause of urinary tract pain as well. Hepatobiliary disease in the cat can cause acute abdominal discomfort. Cholangiohepatitis and biliary tract obstruction, cholecystitis and neoplasia, all conditions which can cause inflammation, swelling in the kidney and biliary tract, and that can cause significant abdominal discomfort, not only through hepatocellular swelling and hepatic swelling, but also through the associated inflammation that can occur in diseases like cholangiohepatitis, for example, that can cause significant discomfort. Peritoneal disease, this is a really interesting one. Septic peritonitis in cats has the potential to cause significant abdominal pain, and we're going to talk specifically about septic peritonitis in a few slides' time because cats don't always show the sort of abdominal pain we expect them to with septic peritonitis. Hemoperitoneum, the presence of blood, free blood in the abdominal cavity in dogs and certainly in people, can cause quite significant abdominal discomfort. Less so in cats, but certainly it can cause some irritation to the parietal and visceral peritoneal surfaces. FIP and disseminated neoplasia can also cause abdominal discomfort as well. And then to finish off, there are other things that we think about, the body wall, structural things to do with the body walls, the body wall hernias or penetrating injuries. These again can result from projectile injuries, arrows, gunshots, and those sorts of things, or we can get penetrating injury from bite wounds or impalement. We can have hernias that are caused again by bite wounds, blunt force trauma, or sharp trauma as well. The presence of pancreatic inflammation, so pancreatitis or pancreatic neoplasia, is an occasional but quite serious cause of acute abdominal discomfort in the cat. And there's a couple of diseases we see in concert with pancreatitis that can contribute to abdominal pain that we'll talk about in a little bit as well. And again, the reproductive organs, the uterus in particular, can either become infected with pyometra in entire females, or in the pregnant cat, or in the cat that has a pyometra, the uterus can become torsed as well, and that is an infrequent but quite severe cause of abdominal discomfort as well. Finally, there's referred pain. Just as we see in dogs and people, we can get spinal disease, intervertebral disc disease. We can get skeletal problems to do with the spine that can lead to irritation, nerve entrapment of myotome that is associated with a particular intervertebral space, and that can give rise to the presence of apparent abdominal pain. And again, pelvic trauma as well can also contribute to the presence of abdominal pain in the cat. So those are the causes. It's basically a big list of all of our abdominal organs and some of the things that can go wrong with those abdominal organs, and a lot of those can cause acute abdominal discomfort. How do we go about diagnosing the problem in our cats? Well, firstly, we want to get a good history. We get a general history, eating, drinking, so on, weight loss, those kinds of things. Dietary history of dietary indiscretion, whether this cat is an indoor cat or an outdoor cat, or can it go both places. This is going to inform us a little bit about what we need to be thinking about in terms of trauma, perhaps maybe dietary indiscretion, potential ingestion of toxins in the outside world. But also, if we understand the environment the cat is in, we can also understand, if there are elderly people living in the house that may have left medications around that the cat was playing with and perhaps accidentally ingested. Medications that owners give cats is also a very important thing to question owners about. So, and I tend to try to not ask this with any sort of raised eyebrow or judgment in the place, because oftentimes the clients will want to tell you what they think you want to know. So if I say, oh, did you give him any medications, or has he had any paracetamol? And the owner might think, I did give him paracetamol, but I think I get the impression the vet's a bit cross with me. If I had, then they may in fact disguise what they've given or hide that fact from you. So ask a really nice, non-threatening, open-ended question. Say, oh, what medications have you given him? And that way the owner thinks, oh, maybe I should have given my cat medications. And so they're more likely to tell you. So just be aware of how you frame these things. A lot of clients don't know what toxins are in their household either. So it's quite important for us to start listing off 2 or 3 toxins. Is there any engine coolant in that the cat has access to? Do you know what type of engine coolant that is? Are there any disinfectants, detergents, anything that you see a cat lying in or doing anything like that? So those would be very, very important things to try to get out of the client. Dietary indiscretion, we sometimes don't appreciate all that much in cats. Certainly is much more common in dogs because they're usually getting into more things. So dietary indiscretion can be more of a behavioral thing when we're asking clients about that in cats. Does your cat like to investigate things? Does it eat strange things? Do you see it carrying things around in its mouth and so on? Those sorts of questions can help owners out in terms of their recall. Next, we want to talk about the sorts of symptoms that the cat is showing, whether or not there's any vomiting or diarrhea that the owner has noticed. Now, vomiting is not that common a symptom in cats, so if it is a major feature of the history, then that can be quite informative for us in terms of helping us to narrow down perhaps 1 or 2 of the diseases that we'll talk about in a little bit. Any urinary signs? Is the cat going to the toilet any more frequently or less frequently than normal? Are they sitting in the litter tray straining and nothing's coming out? Reproductive symptoms, most cats we find after about 5 or 6 months of age are usually desexed unless they're a stray cat or a breeding cat. But it is important in a cat with an unknown history. Perhaps it's a stray cat that's found its way into a house and is now being looked after. We may not have any idea about reproductive function and whether or not the cat's capable of having any reproductive function. We may not know their desexing history, and so asking clients questions about the cat's behavior, whether or not there are other cats around, whether or not their cat is showing signs of being in heat and so on, can be helpful for us. Neurological signs, anorexia, depression, any muscle tremors or seizures can be quite important to know about. And respiratory symptoms. It's really interesting. A large number of cats with acute abdominal disease can show respiratory symptoms. So tachypnea is one of the most common symptoms we see with many intestinal or many acute abdominal disease. So, is your cat breathing faster than normal? Is it any wheezing, coughing, and those sorts of things that can really help us a little bit. Musculoskeletal signs and weight change, weakness, lethargy, and any perhaps evidence of cachexia or weight loss, any visible bony prominences that perhaps weren't visible a few weeks ago. And finally, just abdominal conformation. The owners may detect that their cat has lost weight, but it's becoming really, really pot-bellied in appearance, or they may have noticed that their cat's really, really skinny, but they have this big abdominal distension. So ask about that. It's oftentimes a lot less obvious in cats than it is in dogs, the abdominal conformation thing, but it's worthwhile trying to ask the owners if they've noticed any change. When we come to look at the cats, we're going to firstly start with an assessment of vital organs. There's airway, the cat's ability to breathe, its respiratory rate, mucous membrane characteristics, its heart rate, its pulse quality, those sorts of things that we do when we're doing a TPR. So I normally am looking at the cat while I'm gaining a history, looking at their respiratory rate, looking at whether or not there's any increase in effort during inhalation or exhalation, when I'm looking at the cat's mucous membranes, whether or not they're pale, whether or not they're cyanotic. And note that cyanosis can be a pretty late and fairly unreliable sign of hypoxia. But if you do see cyanosis present, it's a sign you probably need to terminate the physical exam at that point and perhaps give the cat some oxygen before you complete your physical examination. But certainly airway, breathing assessment, circulatory assessment, and then neurological assessment as well. Neurological exam in a cat, we're really just looking to see if it's alert and responsive to what we're doing to it, whether or not it's able to walk around normally, or whether or not it is having any, any tremors, any altered mentation, or inappropriate responsiveness to what we're doing. Next, we want to assess the abdomen, and we do this firstly just by inspecting the abdominal wall. And it's really important that we have a gentle palpate of the abdominal wall. Basically, I'm just parting the skin, running my hands down the sides of the abdominal wall very, very gently so that I can just get an idea as to whether or not there's any little dents or divots within the abdominal wall, or if there's any unusual bulges coming out of the abdominal wall, because I really want to then focus on those areas to see if they are if they're significant or not, or if the owners noticed these things before. I'm also feeling for any breaks in the skin, and I'm also, I quite like to use a white swab that's a little bit damp sometimes, just to wipe over the skin to see if there's any evidence of fresh blood or dried crusted blood or pus or whatever else that there may be on the abdominal wall as well. Palpation of the abdomen. Take it really slowly. Gently palpate the abdomen on the surface as we've just described, then gently just knead into the abdomen so that you can try to determine whether or not there's any discomfort. Try to identify if there's any presence of abdominal pain, and then see if that pain is localized to any particular region. Is it worse in one part of the abdomen than the other? And then finally, I'm palpating for organs. Identify each and every organ within the abdominal cavity. So palpating the caudal borders of the liver, the stomach, the kidneys, the intestines, the bladder, and then the remainder of the abdominal structure to determine whether or not there's any displacement, alterations in organ size, alteration in organ location, and so on. It's interesting that the sensitivity of abdominal palpation for the detection of ascites in one study in cats was found to only be about 32%. So don't be too hard on yourself if you don't feel something in the abdomen and it's there. There was another study that looked at, or the same study actually, that looked at the sensitivity of abdominal palpation for detection of abdominal masses, and that was found to only be 43.7%. So you and I miss more than half of abdominal masses when we're palpating the abdomen of the cat. So those are important numbers just to have in the back of our mind, particularly when we're in a consultation room with an owner, that there is a lot that we are not going to be able to feel in our physical examination. And when we talk about cats and their unique sort of their unique behavior when it comes to acute abdominal disease, this does mean that you and I as veterinarians and as veterinary technicians are going to be talking to the owners about the need to perhaps work this patient up with a little bit more in terms of diagnostic imaging and blood tests and so on, just so that we can gain some more information. When our physical examination, after we've done our abdominal examination and our initial physical exam, we then just go on to do a complete abdominal examination, look at the oral cavity. A lot of times linear foreign bodies are classically written about being located around the base of the tongue. So make sure you look there, and also look at the remainder of the oral cavity in terms of detecting things like ulceration, for example. If this cat's licked something or eaten something that's particularly caustic and irritant to the mucosa, this could mean that the esophagus and subsequently the stomach is also quite irritated and inflamed. So have a really good look around the oral cavity, an evaluation of the spine, feel for symmetry along the spine and any discomfort or irregularities along the vertebral bodies. And cats have got quite small rectums, so if you have a staff member who has a particularly tiny fingers, then they may be able to do a distal rectal examination, but a lot of times in cats they're oftentimes not going to tolerate that unless they're quite heavily sedated, and certainly we don't want to cause the cat undue distress. Musculoskeletal evaluation again goes hand in hand with our history evaluation in terms of, has this animal lost weight, has it lost body condition, and so on. In terms of what we do when we finish our physical examination, we also know that that our patients have, that our physical examination is not perfect, and so further evaluation is oftentimes necessary for these patients. And we start that usually with just an AFAST ultrasound examination. It's abdominal focused assessment following trauma. The AFAST evaluation, essentially during AFAST, what we're looking for is the presence of free abdominal fluid. That's how AFAST was initially developed. And I'm just going to break out my drawing tools here. Usually, if fluid is within a viscous, it's usually contained within a circular thing. So the bladder and the gallbladder, the stomach, for example, they're circular organs. So fluid is going to be usually within an organ. It would have a circular shape. When fluid sits outside of an abdominal organ, we get the presence of geometric shapes. So we get things like triangles, for example. We get parallelograms. This is not a parallel. We get squares. I'll try and draw a parallelogram. There we go. Parallelograms, we might get hexagons, pentagons, dodecahedrons. Those sorts of unusual shapes are the shapes of fluid that you see when they're sitting outside of an abdominal organ. And if you see those weird shapes, that means you have free abdominal fluid. And if there's sufficient fluid, you can gain a sample of that fluid and you can run some diagnostic tests on it, looking at PCV, total protein, things like urea, bilirubin, amylase, and so on, which we'll talk about in a little bit, to determine where that fluid is from. And you can also do cytology on that fluid. So AFAST evaluation is what we'd initially do just to pick up whether or not we have the presence of fluid or not. And I would conduct a TFAST evaluation. This is a lung ultrasound as well as a basic cardiac evaluation. With lung ultrasound, what I'm looking for is the presence of vertical streaks. When I put my ultrasound probe in the lung, so I'm going to have a little rib here, I'm going to have another little rib here, and I'm going to see a bright line in between those two ribs. That's the air-pleura interface. What I'm looking for then, what I will also see is I'll see a dark shadow underneath each rib. Okay, and that's just the rib shadow because the ultrasound waves can't travel between the ribs. In a normal patient, what I will see is that bright line just reflected at various stages through the lungs. That would be a normal lung, and what I would also see with my lung ultrasound is I would see a little white line, this white line moving back and forth as the patient breathes, and that's really just a sign that I don't have pleural space disease, that my lung is just sliding back and forth against the interior surface of the chest. If you have fluid in your lungs, what you'll typically see is you'll see vertical streaks. Okay, they're vertical streaks. They look white. I'm going to draw them blue, but they're white basically. They're like big, tall arrows. Okay, or big tall wedges, and they run all the way down to the distal lung field. And our depth here is going to be about 3 or 4 centimeters into the lungs, and that is a sign we have some intrapulmonary fluid. So we've got some fluid, be it blood or transudate or an exudate, for example, depending on what sort of fluid it is, whether it's from congestive heart failure, which would be a transudate, or if it's an exudate, such as you might see with pneumonia, for example, or if it's blood that you might see if this cat's being traumatized. So this can give us a little bit of an idea as to whether or not we have any fluid in the lungs, and that can provide a little bit of a clue as to whether or not the underlying disease in our patient. The other thing I'm going to look at is the relative size of the aorta to the left atrium. Okay, so the aorta I've drawn here on the left, very, very well, of course. I'm sure you'll appreciate the aorta diameter here and the left atrium. The normal size ratio is about 1 to 1 to 1.5. So 1 to 1 to 1 to 1.5. Okay, that would be normal. If the left atrium on the right here, if that is more than 1.5 times the diameter of your aorta, then that is a sign you have cardiac disease. And that can be helpful to know, because we know that cats with heart disease can develop thromboembolism, and one of the causes of acute abdomen in the cat may well be thromboembolic disease. That has, thromboembolism may have become lodged in the kidneys or the gastrointestinal tract, could have become lodged into the into the colon, for example, could have become lodged into a part of the liver or the pancreas. So this can be helpful for us to know. So an AFAST and a TFAST combined is very, very useful. Radiography, again, what I'm also going to do is not only abdominal radiography, so ventrodorsal and left and right lateral radiographs of the abdomen, but I'm also going to do the same for the thorax, because I'm wanting to determine whether or not there is a significant pleural space disease, whether or not there is evidence of an increase in pulmonary parenchymal disease, or whether or not there's anything structural within the thorax that's going to be causing a problem. There may in fact be a diaphragmatic hernia, for example. So that's really why we're doing these abdominal radiographs and thoracic radiographs. And also make sure that you are looking at the pelvis, particularly in those patients in which you're suspicious of trauma. Now, a couple of questions there. There's a good question here. What's the best place to scan for a TFAST? Do you have to clip hair prior to see it well enough, especially if it's an emergency? So I love that question, so thank you for asking that. I'm going to try drawing a chest. Just ignore the fact that this is an image of an abdomen, and I'm going to try and draw a chest here. So here's my, oh, no, I'll undo that. I will get a pen instead of an arrow. Here's the dorsal chest, here's the ventral chest, here's my diaphragm down there. Okay, my heart will be sitting sort of somewhere in this vicinity here. Now, the places in which I'm going to place my ultrasound probe, the first thing is that you don't need to shave at all. You just need to wet the fur in between the intercostal spaces on the areas that you're going to look at, just with alcohol. So I just use alcohol, just part the hair, put some alcohol on the skin, and what we're going to do is we're going to do a scan here in the caudal dorsal lung fields. I'm going to do one just around near the base of the heart. I'm going to do one in the cranial ventral lung lobes, and I'm going to do one in the cranial lung lobes up there. And I'm going to do that left and right side of the chest. Okay, so those are usually where I'm going to do TFAST. There's a great textbook by Greg Lissandro called Focused Assessment for Small Animal Trauma with Ultrasound, Focused Assessment with Ultrasound for Small Animal Trauma. It's a great book if you can get your hands on a copy of that. It's really, really good, takes you through all of those views that you need, and very, very nice diagrams as well. If you're a vet education webinar member, I've actually done a lecture on lung ultrasound where we talk about this for about an hour and a bit on specifically all the lung patterns you can see with that as well. But that's if you're a webinar member, you can log into the library and have a look at that as well. How significant is not seeing flow at the aortic bifurcation in a suspected feline aortic thromboembolism cat, and do you get false positives? Josie, I'm going to leave that question for a bit later on. I might answer that one by email because I know I'm cognizant of the time for the lecture there today. So thanks for that. Just remind me towards the end and I'll get that for you. After we've done our AFAST and our TFAST ultrasounds, we want to do some further evaluation. If depending on your skill level, you may feel super comfortable doing full abdominal ultrasound. If you're not, then either consult with your colleagues in your practice, or perhaps look at emergency referral to an emergency center. But if an emergency center referral is not on the cards for you, or referral to a medicine specialist to be able to have a good look at your cat's abdomen with an ultrasound, try to scan as many organs as you can and look up and down the entire length of the organs. Both kidneys, the liver, get as much of the liver in your scan as you can. Move from side to side. Make sure you can see a gallbladder. Make sure you can see the spleen. Trace it from one end to the next. Always tilt your probe at 90-degree angle after you've looked at the organ in one plane so that you get to view it in another plane. Look for the bladder and so on, but do the best you can with the resources that you have to try to get some more information. I'll tell you a little bit more about the value of ultrasound and the accuracy of it as we go through the sessions. Moving on, blood test, CBC, biochem, urine analysis, and having a look at the effusion. If you manage to get some effusion, do cytology on it, measure lactate, do some chemistry, so urea, amylase, bilirubin, lactate, and so on, and obtain a sample for culture just in case you are dealing with a septic abdomen as well. So that's kind of our workup, and it's very, very similar to the sort of workup we do in the acute abdomen in the dog. Before we get on to the journal articles that I do want to talk about that sort of shed a little bit more light on what we do, and more importantly what we don't know about the acute abdomen in the cat, I do want to draw your attention to the course that's starting on November 15th. Feline Emergencies. It's a 4-week online course. It's race approved for those of you who need race credits, race approved for 20 CPD points. We have weekly tutorials that are held in a room very much like this one, where we go through the course topics, and we also have a bunch of additional resources, including additional literature reviews. We have journal articles, we produce cheat sheets and handouts, ultrasound guides, those sorts of things as well, right throughout the course. 4 fun-filled weeks talking all about feline emergencies, everything from respiratory distress and cardiovascular emergencies in the cat through to talking about abdominal emergencies, talking about diagnosis and management of sepsis and shock in the cat, plus neurological emergencies and urinary tract emergencies and gastrointestinal emergencies as well. So lots and lots of stuff we're going to cram into these 4 weeks. So we do hope that you can join us for that. And we are also working to get you a free ebook from CRC Press as well to augment the resources that you have too. So let's move on and see what's so different about cats, because a lot of what we've talked about is fairly generic and it may apply to dogs as well. And this lecture is all about acute abdomen in the cat. Well, let's just take a look at this image here. This image was taken from a cat that had respiratory, it's a post-mortem image, obviously. It had respiratory distress as its predominant, as its only clinical sign. Severe respiratory distress. And what do we see here? Well, what we see here is we see a colon that has that is very, very ischemic. Obviously, this cat's passed away, but this is evidence here that we have a significant decrease in blood supply to this colon. This is a very, very fresh post-mortem in this particular cat. This colon here is devitalized. This animal had abdominal disease, but presented to the vet with respiratory distress. Comorbidities: the cat had a packed cell volume of around 78%. It had severe respiratory distress and central nervous system obtundedness, so it was very, very poorly responsive. We suspect this cat had severe thromboembolism, and in this colon had abdominal disease, was extremely severe when obviously this was further investigated. So, a cat with necrosis of its colon presents with respiratory distress as its predominant clinical sign. Let's have a look at some literature and see if we can find anything more about acute abdomen in the cat. Let's start with what we know about septic peritonitis. We're going to go through a few journal articles here. This is a journal article, a retrospective study of surgically treated cases of septic peritonitis in the cat. I like this article because it was about surgically treated cases of septic peritonitis. So the surgeons were able to visualize what was going on in the abdomen. There were 26 cats with surgically treated septic peritonitis. The cause of the septic peritonitis in these cats varied. Some had trauma, some had previous surgery for intestinal surgery, some had neoplastic lesions. There were a couple of cats with intussusception, and there were some cats in which the cause of septic peritonitis was undetermined. There was no visible cause for why these cats had an abdomen full of purulent material and bacteria. Okay, there was simply no identified cause. The clinical signs, the most common clinical signs, were lethargy and anorexia. Bear in mind, these are cats with confirmed cases of septic peritonitis. They had purulent material free-floating in the abdominal cavity. Abdominal pain was only present in 38%. Okay, so this means that 62% of cats with a septic abdomen in this collection of 26 cats had no abdominal pain, even though they had purulent material free-floating in their abdominal cavity secondary to trauma or wound dehiscence, neoplasia, or intussusception. Vomiting was present in about 42% of cases. So again, less than half these cats were showing gastrointestinal symptoms, despite many of them having surgery and intussusception, for example. So these cats are trying very hard not to be found out that they have septic peritonitis. 26 cases. So this here was the same 26 cats. The pathology in these cats, blood lactate, it found, was higher in patients who were non-survivors. So if the patients had a blood lactate that was higher than the reference range, they were more likely not to survive. And I'm going to talk more about that in the next slide. White blood cell counts, glucose, and total protein, there was no statistical difference between survivors and non-survivors in these patients. Survival to discharge was 46%, so just under half of these cats with septic peritonitis actually went home, which is not the greatest survival rate, but it's not terrible either, because nearly half of these cats with septic peritonitis will survive till discharge. The duration of their hospitalization was an average hospitalization day of around about hospitalization stay of around 7 days. Now contrast that with this next study here, which looked at prognostic indicators in cats with septic peritonitis. There were 83 cases with septic peritonitis diagnosed by cytology or culture. Okay, so these are animals with an abdominal effusion. It's been diagnosed as being septic on the basis of cytology or culture. The cause that was found subsequently in these patients through surgical exploration, diagnostic imaging, and so on, involved either trauma, intestinal wounds dehiscence, the presence of pyometra, grass awn migration, believe it or not. So in this particular case, the patient had no fresh wound, but they found a grass-orn migration through the abdominal cavity. So this might be something to think about in those patients in which there doesn't appear to be a structural cause for septic peritonitis. Biliary tract leakage and bile peritonitis, penetrating wounds, or septic peritonitis from urinary tract origin. Note the prognostic indicators. The higher blood glucose was negatively correlated with survival. So these cats presumably have a higher sympathetic and adrenal gland stimulation. They have insulin resistance, peripheral insulin resistance, and higher blood glucose was negatively correlated with survival. This is really important. Okay, this is one of the key takeaway messages from tonight's session. Early antibiotic therapy was positively correlated with survival. This is exactly the same as we see in dogs, and it's exactly the same as we see in humans. In human beings, there is an 8% increase in mortality rate for every hour that antibiotic therapy is withheld in patients with septic abdomen, so with septic peritonitis, okay, or with sepsis. So early antibiotic therapy is critical. It's positively correlated with survival. What antibiotics are we going to use for these patients? Start off with beta-lactam antibiotics, something like a first-generation cephalosporin or amoxicillin. Amoxicillin has a better anaerobic spectrum and perhaps a slightly better gram-negative anaerobic spectrum than does a first-generation cephalosporin. So that's usually the one I go for. You don't necessarily need to add in a lot of other antibiotics to your treatment if you're unsure at that particular point in time. But the key is early antibiotic therapy is positively correlated with survival. Now, in the last study, blood lactate, if that was high, animals were less likely to survive. In this study of 83 cats, we have blood lactate as well as CBC and biochemistry. Their levels were not correlated with survival. Even patients with elevated blood lactate concentrations, they had an equal chance of survival as those that had low blood lactate concentrations or normal blood lactate concentrations. Survival of this group of patients was nearly 70% survival to discharge. Okay, so this is septic peritonitis in the cats is potentially a condition that has much better survival than it does in dogs. So the take-home messages for septic peritonitis in cats. Abdominal pain may only be present in less than half of cats with septic peritonitis, 38% in that first study we looked at. Indicators like blood lactate and blood glucose might inform prognosis, but we don't have enough evidence to say that, yes, high blood lactate equals you're more likely to pass away from your disease. So, you have to take the blood test results in conjunction with what else is going on in the patient. Clinically, how are these patients going? Appropriate and early antimicrobial therapy can improve outcome, and just beta-lactam antibiotics, we're going to use intravenous formulations for these antibiotics because we want high concentrations nice and early in our patient's treatment. So intravenous amoxicillin, or if you've got amoxicillin and clavulanate in an intravenous form, that's how we would use it. In some cases, in cats with peritonitis, the cause is not able to be identified. Okay, so this is something that where we may open up a cat's abdomen because it's septic, and we look around and we can't find what's wrong, and it will cause you and I a lot of stress because we like to find something that we can fix, right? And sometimes that's not possible in our patients. So in some cases, the cause can't be identified. And overall prognosis, can be between, in these two studies, between 46 and 70%. So this is a serious disease, but it doesn't necessarily mean the patient is going to die. Let's have a look at gastrointestinal ulceration and perforation. This is really interesting. This study here looked at spontaneous gastroduodenal perforation in 16 dogs and 7 cats. So they had 7 cats with gastroduodenal perforation. The clinical signs of a rupture of the intestinal tract, okay, gastroduodenal perforation, were lethargy, weight loss. So this gives us an idea that maybe some of this gastroduodenal perforation is part of an underlying disease condition that may be contributing to perhaps some pathology in the days to weeks before the animal acutely decompensates with a perforation. So maybe this animal is hemorrhaging, for example, through an ulcer, so they have associated weight loss and a decrease in PCV or something like that. Okay, so vomiting is key here. Cats don't often vomit, so this is an important clinical sign to be thinking about when we're thinking about gastroduodenal perforation. Anorexia, dehydration, and shock. So these cats have got shock, they've got fluid loss, okay, as well as the normal signs we see in any sick cat, which is lethargy and anorexia. But these guys oftentimes have weight loss and vomiting and clinical signs of shock. Interestingly, evidence of gastrointestinal bleeding was absent in 80% of cats. These are cats that are bleeding from gastroduodenal ulceration, okay? They don't have any signs, no melena, no hemoptysis, or anything like that. Abdominal pain was present in only 20% of cats as well. So again, this is a serious disease that cats just aren't showing any signs of. Diagnostic findings, however, were really informative. Neutrophilia was a really common finding in these cats. So we've got a cat who's dehydrated, maybe showing signs of shock, who's got a neutrophilia. This is going to be a reactive neutrophilia in response to increased bone marrow activity. Anemia was present in 29% of cats. Radiography, because there was free abdominal fluid, and there was a bit of loss of serosal detail, and in some cats they found free abdominal gas. An ultrasound, free abdominal fluid was found, but gastrointestinal ulceration was not evident. These are 7 cats with perforation of their intestines. These are board-certified radiologists doing these ultrasounds. Okay, so these are tricky things to find. The etiology, liver disease and gastrointestinal neoplasia were the most common were the causes in these animals. So lymphoma and angiosarcoma. The outcome of spontaneous gastroduodenal perforation was 14% survival, okay? Partly probably due to the underlying disease process and the fact that it had been going on for a little while with liver disease and neoplastic disease and perhaps non-resectable lesions and so on. There was another case report here of successful surgical management of spontaneous gastric perforations in 3 cats. These 3 cats had gastric ulcers, the clinical signs, lethargy and reduced appetite. Intermittent vomiting, again, not raging vomiting, just intermittent vomiting. These cats had abdominal distension, tachycardia and dehydration. So these patients were, starting to show signs of cardiovascular compromise and fluid loss, and obviously they'd lost appetite, they perhaps weren't drinking all that well. All of these cats had had non-steroidal anti-inflammatory administration within the past 7 days. So that is going to be a real big clue. Okay, so these cats had all had non-steroidal anti-inflammatory drug administration within the previous 7 days. Imaging, radiography showed the presence of pneumoperitoneum as well as the presence of intestinal gas. Now, pneumoperitoneum is an interesting one. I'm going to give you a tip. If you want to diagnose pneumoperitoneum in the cat, there's a couple of things you can do. The first is, the first radiograph that you're going to want to take is have your patient sitting in sternal recumbency. Just before you're going to take their radiograph, put them in lateral recumbency and take your radiograph. Okay, where you're going to find gas is just cranial to the liver, between the liver and the diaphragm. You might see a little bit of gas in that region there. Then what you want to do is leave your patient in lateral recumbency for a few minutes. What this will do is it will make the gas rise to the top, the uppermost side of your cat when it's in lateral recumbency. And then what you're wanting to do is you want to do a dorsoventral radiograph. So your cat will be sitting in sternal recumbency, okay? So you're going to have your cat lying on its side until just before you want to take its sternal position, so dorsoventral radiograph. Then you're going to sit it in dorsoventral view, and what you'll see on your radiograph is the gas will tend to have accumulated because your cat's been in lateral recumbency. It will have accumulated between the abdominal wall and the intestine. So you might see some radiolucent material gas sitting between the abdominal wall and the intestines on one side of the abdomen, less likely the other side, which was the ventrally dependent one. So that's just a tip from a radiologist that I've tucked away in the back of my mind. I find it really, really helpful. Blood test, one cat was anemic. Both these cats had, all of these cats had neutrophilia. Abdominal radiography with pneumoperitoneum was the most sensitive test in this in these 3 cats here. I've actually seen spontaneous gastric ulceration without perforation in a cat that had sodium carbonate as an emetic. So vet had given this cat sodium carbonate as an emetic, and the cat had not vomited. And sodium carbonate is very, very irritating. It used to be used in human children. It was found to cause severe esophageal ulceration. They stopped using it. And we used to use it in dogs a little bit, but I don't use it anymore simply because it's so caustic and I'm worried about causing esophageal irritation in dogs. We never used it in cats. But unfortunately, this cat did have some washing soda crystals given, so sodium carbonate crystals. The cat had not vomited after the sodium carbonate crystal had been given. And so the sodium carbonate crystal led to an erosion into this cat's gastric wall, and the cat began to bleed profusely into its abdomen, presented to us with severe hemoptysis, so vomiting up blood, and with a history of this. So we ended up, the cat had a PCV of 12. We took the cat to surgery and actually had to excise the bleeding ulcer that this had caused. So vomiting, definitely in these cats. Some sort of history of medication beforehand. Very informative. There was 8 cases of gastroduodenal ulceration and a review of the literature that was published in 2002. Clinical signs, vomiting was the most common sign. Abdominal pain, again, only 33%. A couple of articles ago said only 20% of them had abdominal pain. Anemia was present in all of these cats, but neutrophilia, 100%. So neutrophilia, vomiting, lethargy, and anorexia, and some sort of history of something going on with these cats, maybe chronic illness with weight loss or some medication, really raises an index of suspicion of gastroduodenal ulceration. The pathology in these cats was in one cat, primary gastrinoma, secondary neoplastic lesions, and non-neoplastic lesions like inflammatory bowel disease and so on in these patients. And, here we go. This is another case here with gastroduodenal ulceration or necro-ulcerative hemorrhagic gastritis in a cat secondary to administration of hydrogen peroxide, another emetic agent that we don't use in cats. This cat had 3% sodium hydrogen peroxide given and had an acute onset of hematemesis within 24 hours. No significant findings on radiography, no significant findings on ultrasound, but at surgery there was ulceration to 60% of the stomach. It was necro-ulcerative hemorrhagic gastritis in this particular cat. A cat passed away, I think, in that case study. So what do we summarize about gastroduodenal ulceration and perforation? That lethargy, anorexia, and vomiting are the most common clinical signs. Abdominal pain may be present in as few as 20%, so it's not a consistent finding. However, neutrophilia is common, and anemia can be present even without significant external sources of bleeding. So if you get that packed cell volume and it's low and you can't say, well, there's no melena, no hematemesis, no hemoptysis or anything like that, then don't be caught out by thinking this animal doesn't have a bleeding problem in its gastrointestinal tract. Radiography is relatively insensitive except where you've got perforation, where you can pick up the presence of free peritoneal gas, and that's highly diagnostic for bowel rupture. So if you see that free peritoneal gas, you've got to go in and explore these patients surgically. Given the vague symptoms, a patient evaluation is really important to help detect gastroduodenal ulceration and determine an underlying cause. And if you start off with your physical exam and your basic assessment and you don't find any answers, and your owners decide that they just want to go with supportive care, if your patient is getting worse, don't be afraid to revisit the patient and say, look, I think we need to do more investigations, because oftentimes there are secretive diseases inside of cats that we need to worry about. Now, here's an interesting one, gastric dilatation volvulus syndrome. We think of this as a canine problem. Does it really occur in cats? Well, yes, it does. There is acute gastric dilatation in cats, a case series, 2 cases, and a review of 8 others that were in the literature already. This was written in 1996, this journal article. The signalment, not really that helpful, no breed or sex predilection, and pretty much any age based on all of the cases that were reviewed, 11 weeks to 11 years of age. Presenting signs, abdominal distension and dyspnea were the 2 big clinical signs. There were some comorbidities. Some of the cats had diaphragmatic hernia. Some of the cats had respiratory distress, and some of them had gastric torsion as well as gastric dilatation, as well as gastric dilatation. And I see Claire's diagnosed the GDV in a cat, so have I. It was the smallest little GDV I think I've ever done. So let's have a look. These cases were managed with fluid therapy and pain relief. Decompression in cases of simple dilatation is something that can certainly be attempted, and with cases in which you make a radiographic diagnosis of dilatation and volvulus, you need to derotate and gastropexy and surgery the same as you would with dogs. This is really important, and thoracic radiographs can be quite important because diaphragmatic hernia certainly was a problem in one of these cats. Okay, prognosis in patients with respiratory distress, they had a worse prognosis than patients who didn't have respiratory distress, but overall mortality rate was around 30%, so still a 70% chance of survival if you can manage these patients well. Now let's have a look at this other study here. This is spontaneous GDV in 2 cats. This was published 2 or 3 years ago. Respiratory distress was the primary complaint on presentation. Remember right at the start of the session when I said, some cats are really crafty and they will present to you with serious abdominal disease, and they'll say, look at me, I've got trouble breathing, I've got respiratory distress. But in actual fact, you have gastric dilatation, volvulus syndrome. Radiography in these patients confirmed volvulus in 1 cat. Both these cats had distended painful abdomen, respiratory distress. Radiography said 1 cat has gastric dilatation volvulus, the other one doesn't. They both got taken to surgery. They both had GDV. This is important even for dog GDV, even for canine GDV. Sometimes your gastric dilatation volvulus syndrome, the volvulus can be 90 degrees. It could be 120 degrees. It doesn't necessarily have to be 180 degrees, which is what we're all taught in vet school. So sometimes you don't see 2 gas bubbles. You don't see that double bubble in the stomach, so the 2 gas-filled chambers in the stomach. Sometimes you just see 1 gas-filled chamber in the stomach. So this can catch you out. Again, when I'm thinking about patients with gastric dilatation versus gastric dilatation volvulus, there's 2 things that come to mind. The first is that a gastric dilatation may precede the volvulus. Okay, so I might have gastric dilatation and a few hours later my stomach could twist over on itself. The second thing is that the patient's stomach may not completely twist 180 degrees. In a 90-degree torsion, you might just get a bit of displacement of the pylorus, but it may not necessarily lead to a compartmentalization of the stomach. So just be aware of that. And if your patient is not improving, either repeat the imaging or talk to the owners about potentially having exploratory surgery. And this series of 2 cases here would highlight that for sure. There was also another case here, a case report of 3 cats, gastric dilatation volvulus associated with diaphragmatic hernia. These cats all presented with acute dyspnea, abdominal enlargement and shock. Treatment, oxygen therapy, needle decompression and nasogastric tube placement to try and decompress the stomach. The findings, really diaphragmatic hernia should be considered as a possible comorbidity or causative factor for GDV in cats. So if you suspect or identify GDV on radiographs, just be aware that there may be a small or even a large diaphragmatic tear. It's not always obvious on radiographs either. So our summary of GDV. Respiratory distress and abdominal distension are the most common presenting signs. So this, we just add GDV to our potential list of causes for cats with respiratory distress. Abdominal radiography may not be diagnostic of torsion in some cases. Some of these patients may have comorbidities. They may have underlying respiratory disease that has led to aerophagia and subsequently gastric dilatation and volvulus, or they may have diaphragmatic hernia. Exploratory laparotomy and surgical management may be required in patients with apparent simple gastric dilatation that don't respond to initial gastrocentesis or passing a nasogastric tube. Let's talk now about intussusception. There was a bunch of cases here, a review of 36 cases looking at intussusception in dogs and cats. Among these dogs and cats, there were 9 cats that had intussusception. They all had clinical signs of vomiting, depression, anorexia. Interestingly, diarrhea that we don't often see in cats. Abdominal pain present only in 30% of cases. So again, this is a serious disease causing partial, in some cases complete complete intestinal obstruction, and abdominal pain is just not a major feature of these patients. Physical exam, 30% of cases, that should have 30% of cases there was a palpable mass. Abdominal palpation, we've already said, revealed abdominal pain in only 30% of cases and dehydration in 27% of cases. So these cats were trying very hard to get on with their lives even though they had intussusception present. Imaging intestinal obstruction was identified in 50% of cases on radiography. So that's kind of disappointing. We like to think that we might pick up an intestinal obstruction, but it was only present in 50% of these cases. When it came to surgery, and all of these cases progressed to surgery, the ileocolic junction was the most common site. We expect that in dogs as well. But there were oftentimes significant serosal adhesions at the intussusception site. So there was a lot of adhesions from surrounding intestines at that intussusception site, and 11% of these cases had peritonitis. There was another study here looking at histological examination of the intestine of dogs and cats with intussusception, of which there were 18 cats. 17% were at the ileocolic junction. This is less than the previous study, but 72% were located somewhere along the jejunum. Okay, 72% were in the small intestine, and among which the majority were in the jejunum, a few were in the duodenum, and 11% were actually in the colon as well. In terms of etiology, this is really interesting. Lymphocytic plasmacytic enteritis, so inflammatory bowel disease, 22% of cases. Neoplasia, 27% of cases. So there's over 50% of cases here, or 49% of cases, that are neoplastic or inflammatory bowel disease cause for intussusception. This tells us when we're doing surgery on these patients, we need to biopsy them, find out what's going on. This is not something that just occurs all by itself. Other causes included pancreatitis, pyogranulomatous peritonitis, and hepatocellular carcinoma. This also tells us when we're doing surgery for an intussusception, we need to evaluate the entire abdominal cavity and biopsy, biopsy, biopsy everything you can see that is abnormal, because you might unearth something that is going wrong with these patients. So about half of cats with intussusception have an underlying intestinal disease, either related to inflammatory bowel disease or neoplasia. So make sure you do histopathology of the intussusception and other intestinal sites. Endoparasites are also a possible cause. Concurrent diseases like pancreatitis, peritonitis, and liver disease are relatively common, so we need to be aware and get biopsies and investigate function of these organs. Radiography's got a pretty low sensitivity in detection of intussusception, and when we go in to do surgery, it's not usually a nice, clean, easy to find surgery. Well, it's easy to find, but you need to break down all of these adhesions. Oftentimes these adhesions are so severe that it involves us or necessitates us doing intestinal resection and anastomosis. Yeah, good question about what about kittens, underlying disease. That's where endoparasites come in, I think, is probably the most common cause in kittens for intussusception. Great question, I would say. Thank you for that. There's another twisty sort of bowel condition, intestinal volvulus and colonic torsion. Let's have a look at this. There was a single case study, a 12-year-old cat who had chronic diarrhea of several months duration, with a one-day history of anorexia and depression. So diarrhea, all of a sudden, anorexia and depression. That could be a sign of a disastrous disease in a cat, or it could be a sign that the cat is just not feeling all that well today and has nothing wrong with it. However, you know, this is, and I say that with a bit of tongue-in-cheek because anorexia and depression is so common in terms of these patients. And I think that we need to really be mindful of the fact we might end up having to work these patients up quite intensively. The clinical signs in this cat were hypothermia, it was cachectic, so chronic diarrhea, it was dull and dehydrated, and on abdominal palpation it was a large gas-filled structure that was not painful in the abdomen. Okay, it was non-painful in the abdomen. So here is this large gas-filled structure. In fact, there's three gas-filled loops here in the colon that are all part of this volvulus of the colon in this cat. So there was a large gas-filled colon that was U-shaped on ventral dorsal view. The gas-distended descending colon terminated in a rounded end, which indicated a complete obstruction. A small diameter red rubber feeding tube was not able to be passed per rectum and to relieve the obstruction. So if you see one of these blind ending sacs to a large gas-filled colon, passing a red rubber feeding tube up the rectum can, if you're not able to pass it, that might give you a clue that this might be an issue, intestinal volvulus, large bowel colonic volvulus colonic torsion. The volvulus was at the root of the colonic mesentery. There was torsion of the distal colon just cranial to the pelvic inlet. They excised the distal ileum, the ileocolic junction, and the devitalized segment of the colon was required. The cat didn't do well. It had persistent hypotension after surgery and was euthanized. This is a radiograph that came from that case study there. We see this, this rounded end at the distal end of the colon there. Interestingly, a small intestinal volvulus in dogs can be pretty disastrous. I don't know of that many dogs that I have seen and been able to treat in which there's been a successful outcome. It is really, really severe disease. But this series of 2 cats had successful treatment of small intestinal volvulus. 2 cats, clinical signs, lethargy and anorexia and vomiting. Physical examination, these cats were in shock. They had mild abdominal distension and discomfort. There was gas-filled loops of bowel palpated and a palpable abdominal mass. Diagnosis, radiography, okay, what they see here is that there was gas-distended small bowel, there was free abdominal gas, and you see the free abdominal gas. I'm going to point to it with the arrow up here, okay? This is this black shadowing in the retroperitoneal space here. And there's just generalized loss of serosal detail in this radiograph. Not a nice clear film here. These cats were anemic, leukopenic in one, leukocytosis in the other. They were both thrombocytopenic and had pre-renal azotemia. At surgery, abdominal effusion was found. There was between a 270 and 360 degree clockwise rotation of the small intestine around the mesenteric root, with intestine herniating through a mesentery in one cat. Both cats survived due to discharge. They needed significant small intestinal resection and anastomosis, so they had chronic soft feces due to short bowel, but both cats survived to discharge, and to follow up, they apparently did quite well. So what do we know about intestinal volvulus and torsion? Well, abdominal distension associated with gas-distended bowel are pretty common clinical findings in amongst the small number of case reports that we have, along with cardiovascular shock and being depressed. Radiography is the most useful diagnostic tool because it allows us to visualize the gas-distended loops of bowel. If we can't pass a small bore feeding tube into the colon to relieve gas pressure in the colon, that might assist us in making a diagnosis of colonic torsion. And small intestinal mesenteric torsion carries a much better prognosis on the basis of those two cats than it does in dogs. Finally, just going to wrap up with a couple of things. Constipation in cats. There was a large study looking at retrospective evaluation of risk factors and treatment outcome predictors in cats presented to the emergency room for constipation. They said patients with abdominal pain on palpation were less likely to defecate following giving them an enema. Giving other treatments like fluid therapy and laxatives increased the likelihood of a successful enema, but were not statistically significant in determining outcome. Older and more overweight cats were more likely to present with constipation. Cats with constipation are more likely to have high ionized calcium that they found in this study, and cats with chronic kidney disease were more likely to suffer from constipation owing to smaller blood volume and so on. Fluid or lubricant enemas resulted in defecation in just over half the cases. Nearly there. We're just going to talk about uroabdomen just before we finish off. Uroabdomen, the study here was an association of abdominal effusion with a single decompressive cystocentesis prior to catheterization in male cats with urethral obstruction. This was published just last year. This study I found really, really interesting because we're oftentimes concerned when animals present to us with urethral obstruction that if we perform cystocentesis that we could in fact cause a small hole to be present in the bladder and that we'll get a uroabdomen afterwards, and that might make things worse for our patients. Uroabdomen can certainly cause abdominal pain and can cause quite significant electrolyte and acid-base abnormalities. So that's the reason why we might not want to cause a uroabdomen with our needle. But in this study here, what they found was that 33% of cats had a uroabdomen prior to performing cystocentesis, and that 49% of them had a uroabdomen following cystocentesis. So what they did find was that, yes, we did cause a small uroabdomen by performing cystocentesis before urethral obstruction in these cats. However, post-cystocentesis uroabdomen volumes were pretty small and they did not appear to result in complications like significant electrolyte or acid-base abnormalities. So I think the hole probably fairly quickly seals up in most of these patients. But that was the results of this particular test, so a particular study. So that was quite interesting and quite informative. Just want to close it off with the value of ultrasound because, ultrasound is, we're oftentimes taught is the value of it is very operator dependent because it's an acquired skill. People who do significant postgraduate study and skill development in ultrasound can get really good at it, but it is a skill that does require quite a lot of finesse there. So there was a paper published looking at the correlation between preoperative ultrasound findings and clinical, intraoperative and cytopathological as well as histopath diagnosis of acute abdomen in 50 dogs and cats. What they found was that there was good agreement between the ultrasound diagnosis and intraoperative findings in about 86, nearly 87% for both primary and secondary lesions. Surgical diseases were not identified by ultrasound in 13% of cases taken to surgery. The most common were bile duct rupture, intestinal foreign body, and GI perforation. And that's borne out, I think, with some of those studies we looked at tonight with gastrointestinal perforation in cats. Cytology and histopath examinations corroborated the ultrasound findings in about 86% of cases of primary disease and 66% of secondary lesions. So their summary was that care should be taken when interpreting gastrointestinal perforation, pancreatic neoplasia, omental tumors, and gastrointestinal foreign body and bile duct rupture, as these had a higher incidence of either not being detected or being misinterpreted with ultrasound. So we'll go through that again. GI perforation, pancreatic neoplasias, omental tumors, GI foreign bodies, and bile duct rupture. Ultrasound has a much lower sensitivity for detecting these. Other diagnostic tests like palpation and radiography, when used in conjunction with ultrasonography, can improve diagnostic sensitivity. So ultrasound is really, really good but it doesn't detect everything. So it just underlies the importance of doing thorough physical examinations, thorough hematological, biochemistry, fluid analysis evaluations. Don't forget radiographs, don't forget contrast radiographs, don't forget repeat radiographs and repeat ultrasounds as well, and surgery. That is what I had for you this evening. Thank you so much for sticking around. I know I've gone a little bit over time. This has been a free lecture brought to you by Vet Education on the acute abdomen in the cat. Don't forget, we have a course, Feline Emergencies, that's coming up starting November 15th, so not too many days away. There's still time to register. We'd love to see you on this course. We're going to talk a lot more about feline emergencies, respiratory, gastrointestinal, cardiovascular. We'll talk about trauma, sepsis. We'll talk about urinary tract emergencies. We'll talk about neurological emergencies, a whole bunch of stuff. It's going to be a lot of fun there. I'm happy to take any questions that you may have this evening.